Assalamu alaikum. Hello dear students. My name is Islam Shereen. I'm an assistant professor in the Department of Ophthalmology, and today we will try to cover the pupillary examination and disorders, and in the second half of the lecture we will try to cover the common neurological visual field defects. So let's kick off. The pupil examination is an essential skill, not only for ophthalmologists but also for other specialties like internal medicine doctors, pediatricians, intensive care doctors, and neurologists. Our pupil size differs from one person to another and from one time to another in the same person. This depends on the resting autonomic tone. We know that elderly people tend to have smaller pupils than young people because they have less sympathetic outflow. In addition, we tend to have a larger pupil at the time of fear, for example, because of the higher sympathetic flow. A second determinant is the light. We know that in bright light we tend to have a smaller size pupil, and we have larger size pupil in dim light to allow more light to go inside the eye. And those who use glasses know that they have worse vision during the night time because when the pupil becomes dilated, the refractive error becomes more pronounced. The third determinant is the near reflex. We tend to have a smaller size pupil when we focus on something near, like when we read, and this improves the quality of the vision and the depth of focus. And finally, as we will see later on, some local mechanical factors may affect the pupil size. So the first step in the examination of the pupils is to look in the normal ordinary room light and to observe the size and the shape of the pupils. When we are having a person with normal pupils, we document that in the examination sheet by saying that the pupils are rounded and reactive. We abbreviate that as RR, or we say that the pupils are perla. Perla stands for pupils are equal in size, reactive to light and accommodation, and we will see the meaning of that in the next few slides. So the first abnormality may be in the pupil shape. This usually results from a local intraocular damage to the pupillary sphincter. As we can see here, this patient sustained a blunt trauma to the eye and he had a tear to the sphincter pupillae muscle, giving rise to this abnormal shape of the pupil. Or it may result from what we call the posterior synecdoche, or adhesions between the iris and the anterior lens capsule. So this patient had a previous uveitis and he developed some adhesions between the iris and the capsule at those points. So the normal parts which are not affected by the adhesions can dilate properly, but the parts with the adhesion cannot dilate, and this gives rise to this fistone pupil. Fistone means mekashkish. The second abnormality in the pupil is anisocoria, and we will see that in the slides later on. Anisocoria means unequal size of the pupil. So this patient, for example, is having normal size of the pupil. They are equal in size, but this patient has a larger pupil on that side, and this is called anisocoria. After examination of the pupils in the ordinary room light, we move to the pupillary light reflex. Normally, when the light is shown to one eye, that eye will constrict, and this is called the direct reflex, the constriction of the ipsilateral, or the same eye on which the light is falling. The second part is the contraction or the meiosis of the contralateral eye. This is called the consensual reflex. In other words, when the light is falling on that eye, this eye will constrict directly and the other eye will constrict consensually. The pathway of the light reflex involves that when light falls on the eye, it will stimulate the retina and the optic nerve, and then the optic chiasm, and then the optic tract, and then the pupillary fibers, which are different from the visual fibers, will leave and go to the pretectal nucleus in the midbrain. And from there, the fibers will go on in the posterior commissure on both sides to supply the Edinger-Westphal nucleus, which is the parasympathetic nucleus of the oculomotor nerve. And then the parasympathetic efferent flow will go through the third cranial nerve, the oculomotor nerve, and relay in the ciliary ganglion, and then through the short ciliary nerves to the sphincter pupillae muscle. As we notice here, we have a double decussation, one at the optic chiasm, so the fibers from one eye will cross to both eyes at that point, and a second at the posterior commissure. This is responsible for the bilateral nature of the pupillary light reflex. So when we are examining the light reflex, we need to have a dim room, a room with a dim light, and a distant object to give to the patient to focus on, like a clock or a watch on the wall, and then we need to have a small bright light. When we do the examination, as we mentioned, we need to dim the room lights and ask the patient to focus at a distant object, as we try to relax the sphincter pupillae muscle as much as we can by eliminating any light reflex or near reflex. Then a bright light is shown directly into the patient's pupil, slightly off axis. So as you can see here, we are holding the torch close to the patient eye, so that the light is falling briskly on that eye, but we are not holding it directly in front of the patient's eye. We are holding it away from the light of the vision of the patient's eye, because if we hold it directly in front of the patient eye, this will stimulate the near reflex, or what we call the accommodation, and we don't want that. Normally, there should be a brisk, simultaneous, equal response of both pupils. As we mentioned, this eye will respond directly by having a meiosis, direct light reflex, and that eye, even if the light is not shown on it, will constrict consensually. Another important reflex to know about is the near reflex. So when the person focuses on near objects, this will stimulate the retina, the optic nerve, the optic chiasm, and then the visual fibers. Those are not the light reflex fibers, will go to the lateral geniculate body rather than going to the pretectal nucleus like in the light reflex. And from there they will go to the occipital cortex, and then from there the efferent fibers will come back to the pontine centers in the brainstem on both sides, and from there they will go to the Edinger-Westphal nucleus, giving the parasympathetic flow to the sphincter pupillae muscle, giving the meiosis, and to the ciliary muscle, giving the accommodation. And there will be stimulation of the medial rectus nuclei on both sides, giving co-contraction of the medial recti, of both medial recti, which causes convergence. Because when we look at a near object, the eyes need to converge a bit to look at that object. The meiosis improves the depth of the focus, and the accommodation increases the diopteric power of the eye so that we can focus on the near object. So there is a triad in the near reflex. How to examine it? We ask the patient to focus with both eyes on an easily seen target, like a pen or the patient's own finger, and we start to move that object close to the patient's eye, and we observe the convergence and the meiosis. When do we need to do the near reflex? If the patient has a pupil that reacts poorly to light, if the eye doesn't constrict properly with light, we need to check the near reflex. As we can see, this patient having a poor reaction to the light, but a good response, good meiosis to the near. As we can see, when the light is shown on the eye doesn't, the pupil doesn't constrict, but when we bring the finger and ask the patient to focus on that, the pupils, both pupils constrict. This phenomena is known as light near dissociation. The eye with the light near dissociation can accommodate, so it has a good response to near reflex, but it cannot react to light. And this signifies a problem either in the midbrain or in the ciliary ganglion. Again, this eye cannot react to light. When we direct the light to the pupils remains dilated, but when we examine for the near reflex, we find that the pupils goes into meiosis like that. And in those patients, MRI is mandatory to include compressive lesions, especially in the area of the brainstem. Usually, the dorsal midbrain is a common site of lesion which can cause light near dissociation, and this happens because, as we mentioned before, both the pupillary, the visual fibers and the light reflex fibers goes together from the retina to the optic nerve and to the optic chiasm and to the optic tract. Then the separation occurs here. The pupillary fibers responsible for the light reflex goes to the pretectal nucleus in the midbrain, while the visual fibers responsible for the near reflex move on to the lateral geniculate body. So if you have a lesion at that area, it will damage the fibers responsible for the light reflex, causing the inability of the eye to react to light, while the visual fibers responsible for the near reflex will remain intact. Okay, so let's have a break. There is an important concept of, let's say for example, we want to know if Mo Salah is a world-class player or not. So we try to compare his performance against well-known players with a well-known level. And the same principle of this comparison applies to medicine and to ophthalmology as well. بنفس البرنسبل بتاعت المقارنة دي بنبدأ نعمل examination للبيوبلز. احنا في عندنا تيست مهم بيختبر الكونسنشوال رايت ريفلكس اسمه swinging flashlight test. Swing, as you know, means مرجحة. This means that we swing the light between both pupils, and we depend on the nature that the pupillary light reflex is bilateral. So when we shine the light on one eye, there will be co-contraction of or co-miosis of both eyes. And when we swing the light to the other eye, the eye should maintain the constriction. So when the light is shown, for example, to the left eye, both left eye and the right eye are constricted. Then when I quickly move the eye or swing the light to the other eye, to the right eye, the right eye should be in the constriction consensually, and it should maintain this constriction. But what if there is a problem in the afferent pathway of that eye? It will not be able to maintain the constriction. Now first we will see a video about the normal pupillary response. So as you can see here, when the light is shown to one eye, both eyes are constricted, and when I quickly move the light to the other eye, the eye should maintain the miosis or should maintain the constriction if the afferent pathway in both eyes is working properly. Now, if there is an abnormality, it's called a relative afferent pupillary defect or a Marcus gum pupil. When we are examining for the swinging flashlight test, we illuminate the light from the same angle and with the same intensity and for the same time on both eyes, and we swing it quickly from one eye to another. Normally the eye should remain constricted when the light is moved between both eyes, but in relative afferent pupillary defect, if there is a problem of the afferent pathway of one eye, let's say the left eye in this example, when we shine the light to the right eye, both pupils will constrict. This eye will constrict directly and this eye will constrict consensually. When we swing the light to the left eye, the affected eye, the afferent pathway is not working. So the light reflex will be interrupted and both eyes will go into mydriasis. So the left eye will not be able to maintain the constriction and it will go into mydriasis. And when we move the light back to the sound eye, the normal eye, the right eye, we'll find that it was dilated consensually because the afferent pathway of the left eye is not working, and when we move the light to it, it will go again into constriction. So here, for example, when the light is shown to the left eye of this patient, it will constrict. When we move to the other eye, you'll find that there is abnormal response. There is mydriasis going in the right eye when the light is moved there. And if we will move back to the left eye, you will find that it was dilated when the light was shown on the affected eye, and it will go again into constriction when the light falls on it. RAPD means primarily that there is a problem in the optic nerve. It can happen if there is a severe and generalized retinal abnormality, like for example a large retinal detachment or ischemic retinal vein occlusion. The reason why the RAPD happens even with the slight optic nerve disease, but the retinal disease needs to be severe and diffuse, that the afferent fibers are distributed over a large area of the retina, while they are condensed in a small area in the optic nerve. So even a small problem in the optic nerve can produce the relative afferent pupillary defect, while in the retinal condition it should be diffuse and severe. We should understand that the relative afferent pupillary defect does not happen with cataracts and the vitreous hemorrhage. So if you have a patient with cataract and he has a relative afferent pupillary defect, you should expect that there is something wrong with the retina or the optic nerve. And we should understand that relative afferent pupillary defect never produces anisocoria. So both eyes will constrict or dilate together, and they will be of the same size. The problem here is in the afferent pathway. So when the light falls on the affected eye, both eyes will dilate, and when the light falls on the normal eye, both eyes will constrict. They will always have the same size. In contrast, efferent pathway abnormalities, as we will say later on, can produce anisocoria. And we should understand that relative afferent pupillary defect can never be bilateral. As the name implies, it's a relative defect. So we compare the normal eye to the affected eye. If both eyes are affected, there will be no relative afferent pupillary defect. There will be no response in both eyes, no constriction in both eyes. Now we will see another video of the relative afferent pupillary defect. As we can see here, when the light falls on the left eye, it goes into constriction. When it moves on the right eye, it goes into dilation. And when the light is moved back to the sound eye, the normal eye, the left eye, it goes into constriction. When it goes to the right eye, it goes into dilation. This is how the relative afferent pupillary defect looks like. One of the abnormalities that we may see in the pupil is the abnormal pupil size. So the pupils can be abnormally small. A good mnemonic to remember is that pinpoint pupils can occur due to morphine use, organophosphorus poisoning. You know, the organophosphorus is a pesticide that is used in our agriculture. When there is poisoning with this organophosphorus, one of the signs is that pinpoint pupil. And in pontine hemorrhage, patients with brainstem hemorrhage in the pons. Myotics like pilocarpine can produce pinpoint pupil, and this patient, for example, he or she had an attack of angle closure glaucoma. As you will understand in the glaucoma lectures, the angle closure glaucoma we treated by giving myotics and doing a laser iridotomy. Other causes include posterior synechia, senile meiosis, as we mentioned, because they have a low sympathetic activity in comparison to the young people, so they tend to have smaller size pupil. And as we will see later on, there is the Horner syndrome and the Argyll-Robertson pupil. Anisocoria means unequal pupil size. As you can see here, this patient is having a smaller pupil on the right side and a larger pupil on the left side. An means not, iso means equal, chorea means pupil size. And this usually indicates a problem in the efferent pathway or the sympathetic supply, like in Horner syndrome. So in order to have a variation in the size of the pupil, it can never be due to the problem in the afferent pathway. It's usually due to efferent pathway abnormality in one of both eyes. So when we have a patient with unequal pupil size or anisocoria, it's important to determine whether the anisocoria is worse in dark condition or in bright light conditions, because there are various causes for both of those. For cases that become worse in dim light, we should think about problem in the sympathetic outflow to the eye, or what we call the Horner syndrome. So this patient, for example, in bright light will have constriction of both pupils, and the anisocoria is not very evident. The anisocoria gets worse in dim light because the normal eye, the sound eye, can dilate properly because the sympathetic system is supplying the dilator pupillae muscle, while the diseased eye, it cannot dilate properly, so it will remain constricted, and the difference will become more pronounced in dim light than in bright light. In addition, as you can see here, there is a bit of ptosis in that eye. If you are interested in history, this is Johann Friedrich Horner, who was a Swiss doctor who discovered and described, along with two other doctors, the Horner syndrome. So Horner syndrome is caused by interruption of the sympathetic supply to the eye, and usually there is meiosis, which produces anisocoria, which is more pronounced in dark. As you can see, this pupil is smaller than that one. There is ptosis because of the dysfunction of the Muller's muscle, one of the levators of the eyelid. There is anhidrosis of the ipsilateral face and neck, so there is reduced sweating on that part of the face. And there is apparent enophthalmos due to the droopy eyelids. In congenital Horner syndrome, so some babies are born with congenital Horner syndrome, they may have heterochromia iridis. This means that one iris has a different color from the other one. As you can see here, there is a bit of ptosis, there is a bit of meiosis, and the iris is lighter in color because the melanin formation depends on the sympathetic flow to the eye, and when this is interrupted in early years of after birth, the melanin will not develop properly, and the patient will have this different color of the eye. A good mnemonic to remember the features of Horner syndrome is sample. So there is sympathetic dysfunction, anhidrosis, meiosis, ptosis, loss of iris pigments in congenital cases, and apparent enophthalmos. In order to understand what is the etiology of the Horner syndrome, we should understand that the sympathetic flow to the eye originates from the hypothalamus, descends along the spinal, brainstem and the spinal cord till the upper thoracic segments, and then leaves the leaves the spinal cord and goes at the apex of the chest and then through the neck and goes along the internal carotid artery till reaching the eye. The most common site of interruption of this sympathetic pathway is at the area of the apex of the chest and the neck. So apical lung tumors, what we call the Pankos tumor, can produce Horner syndrome. Aortic dysfunction like thoracic aortic aneurysm or dissecting carotid aneurysm can produce Horner syndrome. And as you can see, those are life-threatening conditions. So this is a really serious condition, that Horner syndrome, especially if it is of new onset. If a patient is recently developing Horner syndrome, we need to be alert about that. Other causes will include neck, thorax, or spinal trauma or surgery, and cervical rib. Sometimes we have an accessory cervical rib that can compress the pathway. Another common site of affection is the cavernous sinus. If there is a carotid aneurysm in the cavernous sinus, it can produce Horner syndrome, and again it's life-threatening. Or the final site is the brainstem and the spinal cord, where demyelinating diseases like multiple sclerosis or brainstem infarct can produce Horner syndrome. When we have a patient with Horner syndrome, it's essential to investigate that patient with MRI brain that starts from the base of the skull and going to the mid-thoracic region, because any part in this area can produce Horner syndrome if affected. The second thing is to do carotid angiography, especially in acute or painful cases. So some cases may have pain or headache or along with the Horner syndrome. This can draw the attention to the dissecting aneurysm of the carotid artery. Many patients will show normal results, and we call them idiopathic Horner syndrome. There is another condition that may affect the pupil called the Argyll-Robertson pupil. It's caused by the tertiary syphilis, which can affect the dorsal part of the midbrain. So again, it affects the pretectal nucleus, and thus it produces bilateral, symmetrical, small, irregular pupil with light near dissociation. So the eye will not react to light, but it will accommodate for near. And this is because, as we mentioned earlier, the visual fibers responsible for the near reflex are not affected in that condition. They go to the lateral geniculate body rather than to the pretectal nucleus. And what we need, that when we suspect Argyll-Robertson pupil, is to do serological testing for syphilis and MRI of the brainstem to check if there is any abnormality there. Okay, so we mentioned that anisocoria may be worse in in dim light in Horner syndrome, but it may be worse in bright light, and usually this draws the attention that there is an abnormal constriction of the constrictor pupillae. This may happen in patients, for example, with an oculomotor palsy, a third nerve palsy. As you can see, this patient is having ptosis, and we are elevating the eyelids using an instrument. The eye is turned down and out, and the pupil size on that eye is larger than that eye. When this patient is exposed to bright light, this eye will constrict normally, but this eye is unable to constrict, and this will make the anisocoria worse. This patient sustained a blunt trauma to the eye. He has a hyphema, which is collection of the blood in the anterior chamber, and in addition he or she developed a tear of the sphincter pupillae muscle, making this pupil larger than that one. So this is another example of anisocoria. And again, if this patient is subjected to bright light, this eye will constrict, while the other eye will not be able to constrict properly, and the anisocoria will be worse. Sometimes we have patients suffering pupil involving third nerve palsy. They will have ptosis, strabismus in the form of exotropia and hypotropia. The pupil will become dilated, and it's poorly reactive to light, whether directly, if the light is falling on that eye, or consensually. If you examine the other eye and shine the light into that eye, again, this eye is unable to constrict. That eye, the normal eye or the healthy eye, can constrict both directly. So if you put the light on the normal eye, it will constrict. And even if you will put the light on the affected eye, the normal eye will constrict, because the afferent pathway is intact here. The problem is with the efferent pathway. Sometimes we have patients with dilated fixed pupil that will not react neither directly nor consensually, and usually this indicates an efferent pathway defect. The common causes, I always tend to put that image in my mind when I'm thinking about the causes of the dilated fixed pupil. So as we mentioned, there can be damage or trauma to the sphincter pupillae muscle, pharmacological dilatation, like the dilating drops. When we put them, they block the parasympathetic flow to the sphincter pupillae muscle and can produce this dilated fixed pupil. Trauma to the orbit, causing damage to the parasympathetic nerves there. Ciliary ganglion disease, oculomotor disease, or brainstem affection, causing damage to the Edinger-Westphal nuclei. And finally, the central causes like stage 3 anesthesia or death can produce this dilated fixed pupil. So always go from the pupil towards the CNS. One of the important syndromes to know about is the dorsal midbrain syndrome, or what we call the Parinode syndrome. In this syndrome, there is affection of the dorsal part of the midbrain, and it produces a specific or a peculiar clinical picture, usually described as the triple L. So there is loss of upgaze, lid retraction, and light near dissociation. Let's see some videos about that condition. So this patient is suffering what we call the Collier sign, or the lid retraction. As you can see, the eyes are full, what we call the sunset of the eyes, and the lids are retracted. This patient shows the failure of upgaze or the limited upgaze. When the patient is asked to look up, he cannot follow the object, but when he asked to look down, he can follow the object very easily. in this video we can see that there is a bit of light near dissociation. So when the light is shown to one eye, it's not constricting. When it's shown to the other eye, again it's not constricting. But when the patient is asked to focus on a knee reflex, the pupils will constrict, as we will see now. Look at the constriction here and the constriction there. It's becoming more evident. So there is a light near dissociation, which is one of the features of the Parinode syndrome. Parinode syndrome usually indicates a damage in the area of the posterior part or the dorsal part of the midbrain. This can be caused by hydrocephalus with compression of the dorsal midbrain, compressive brain lesion like a brain tumor, multiple sclerosis, stroke, or midbrain hemorrhage. And in those cases, MRI is mandatory to understand the cause of the lesion and document the site. Now we will move to the second part of the lecture, which is the common neurological visual field defects. So any lesion anywhere in the visual system from the retina to the occipital loop can produce a visual field defects. As we know, the visual pathway involves that there is the retina and then the optic nerve, and then in the optic chiasm the nasal fibers will cross to the contralateral optic tract, while the temporal fibers will remain in the ipsilateral optic tract. The optic tract will get the temporal fibers of the ipsilateral eye and the nasal fibers of the contralateral eye, and then it will go to the lateral geniculate body and then the optic radiation to the occipital cortex. So as you see here, the post-chiasmatic part of the visual pathway is responsible for seeing the contralateral visual field. So for example, the right optic tract or the right optic radiation or the right occipital cortex is responsible for seeing the left part of the visual field and vice versa. So we need to understand a bit more about some terms that we use in the description of visual field defects. We have the term scotoma, which simply means an island of blindness or reduced retinal sensitivity surrounded by a sea of vision. We have the term hemianopia. Hemianopia means loss of half of the visual field. Usually it's a right or left hemianopia, so it respects the vertical midline. And usually neurological visual field defects respects the vertical midline. Altitudinal hemianopia means upper or lower half, loss of the upper or the lower half of the visual field, and usually it happens more with the glaucoma cases. As you can see here, this is a Humphrey visual field, and there is loss of the upper part of the upper half of the field, while the lower half is normal. We have an important visual field defect which is called bitemporal hemianopia. Usually this indicates a lesion at the area of the optic chiasm, which characteristically compresses the nasal fibers from both eyes. Those nasal fibers are responsible for seeing the temporal parts of the field. So those patients will present with loss of the field of the temporal side in both eyes, while they can see the nasal part clearly. So the site is the optic chiasm, and the causes will include pituitary adenoma, craniopharyngioma, and the paracellular meningioma. Now, one of you may ask, why should we know about this? Because if you see a patient with bitemporal visual field defect, probably you will send the patient to MRI for an MRI scan. It will be very nice to point out that to the radiologist that this patient has a bitemporal visual field defect, and please focus on the area of the optic chiasm. This will make things easier for your colleague. One of the terms that we need to know about is homonymous hemianopia, which means loss of either the right or the left half of the visual field in both eyes. So for example, in this patient cannot see the left side of the field, the left half of the field with his right eye, and again he cannot see the left side or the left half of the visual field with his right eye. So this part of both eyes, this half is defective, while the other half, the right half, is intact. And usually this indicates a post-chiasmal lesion, so a lesion beyond the optic chiasm. As we knew, the optic chiasm produce a bitemporal hemianopia, but lesion in the optic tract, optic radiation, or occipital cortex characteristically produces a homonymous hemianopia. And the causes can be stroke, like for example this patient, or trauma or mass lesion. MRI is very useful to document the site and the nature of the lesion. But again, giving a note to your radiologist will help him or her to reach a better diagnosis. In addition to the visual field defects, we can find some other ophthalmic manifestation in those patients. So patients with neurological visual field defects may present with papilledema due to the increased intracranial pressure. So fundus examination is very, very important in those patients, and they can present with extraocular muscle pulses, like involvement of the third, the oculomotor, the fourth trochlear, or the sixth, the abducens nerve, or their nuclei in the brainstem. So this patient, for example, is having an esotropia. The eye cannot move to this eye, the left eye cannot move to the left side, and this is due to an abducens palsy here. Okay? We should note that sometimes the abducens palsy can occur due to the increased intracranial pressure and not due to the mass effect. This is called a false localizing sign. What's meant by that? If you have a mass in the an intracranial mass, it's usually known that it compresses the nearby area. But sometimes it can cause a distant effect because of the increased intracranial pressure, which causes herniation of the brain through the narrow parts like the foramen magnum or the tentorium, and this can produce compression of a nerve away from the site of the lesion, and this is called the false localizing sign. It's not due to the mass effect itself, it's due to the increased intracranial pressure. We should realize that the right half of the visual field, is served by the left side of the retina and transmitted to the left hemisphere. So the right field here will go to that left half of the retina, the nasal retina here and the temporal retina there, and it will move to that area to reach finally the contralateral occipital cortex. We should understand that we can localize the site of the lesion from the appearance of the visual field defects. So the optic nerve lesion will produce a unilateral visual field defect only in the affected eye. A chiasmal lesion, as we mentioned, will produce a characteristic bitemporal hemianopia. A post-chiasmal lesion, like a lesion of the optic tract or optic radiation, will produce a contralateral homonymous hemianopia. So if the lesion is in the right optic tract, you'll find that the left part of the field is defective, whether it's in the optic tract or the optic radiation. Lesion in the right optic radiation will produce a left visual field defect. Lesions in the occipital cortex again will produce a contralateral visual field defect. So if the lesion is in the right occipital cortex, it will produce a contralateral, a left homonymous hemianopia. I hope that I explained things well to you. I hope that you can understand them better. If you have any questions, please don't hesitate to contact me. That's my email. I wish you all the best. Bye bye.